Colleagues, it's my pleasure to be here with you. I will tell something about the role of the sacroplasty in the treatment of sacral insufficiency fractures. First of all, I would like to tell a few words about this type of the fractures. Sacral insufficiency fractures occur in aged cases with osteoporosis after minor trauma. We should differentiate these fractures from the high-energy fractures. These fractures are very similar to osteoporotic vertebral body fractures of the mobile spine. The problem here, actually, the most important problem is diagnosis. This is so, these cases are aged cases. Therefore, most of these cases have degenerative spondylolisthesis, spinal stenosis. Therefore, there is risk of misdiagnosis. And some of these cases are operated with the diagnosis of degenerative spondylolisthesis. Therefore, we should focus on the sacrum in all cases with growing pain, if particularly they have some tenderness over the sacral wing. Diagnosis actually is easy. MRI shows some signal changes, particularly in stir sequences. CT can show fracture line. And if you can check with bone scintigraphy, you can see H sign in the sacrum. So my colleague talked about the conservative treatment. Of course, in some cases, conservative treatment is enough. In mild cases, particularly in cases with no dislocation, you can try it. But if there is no response, of course, you should think about the surgical procedures, sacroplasty or stabilization. Sacroplasty is a kind of vertebral augmentation technique. You fill the sacrum wing with cement. Actually, there are two different techniques. You can go through along the short axis of the sacral wing, or you can go along the long axis of the sacral wing. There is no difference. The main difference, perhaps, is in long axis technique, you can inject much more cement. And as a result, there is much more risk of cement leakage in these cases. I prefer to do actually short axis technique. In this technique, your trajectory is like S1 sacral ala screw placement technique. Therefore, it is easy for most of surgeons. There are some modifications for sacroplasty, like CT-guided sacroplasty, and also we defined for the first time robotic-assisted sacroplasty. In robotic-assisted sacroplasty, there is less risk of radiation exposure. So I would like to present two cases, 62 years old, with pain on the right hip and tenderness over the right sacral wing. You can see here signal changes in the right side, here, and small fracture. There was no response, and this is one of my first cases. At that time, I used to do kyphoplasty balloon during the sacroplasty, but currently I use only vertoplasty. This is also another case, 67 years old, with pain in the left side. A similar story. And you can see here much more signal changes here and fracture line. Of course, you can try to do conservative treatment. But as surgeons, most of these cases actually come to us after conservative treatment. And physical therapy physicians sent to us because they failed to treat these cases. This is intraoperative image and post-operative CT of this case. So far we operated more than 20 cases. There was no fail, no indication for revision and stabilization. 1 night or half night hospitalization, good pain relief. Imagine during the conservative treatment in severe cases, you have to treat patients for weeks or months, but in this case, like compression fracture of the mobile spine, the patient comes to you, and after vertebroplasty, no pain after procedure. So the pain relief after sacroplasty in sacral insufficiency fracture was found to be 90% in our cases. We used also this technique for osteolytic sacral tumors, and the rate of pain relief was almost 70%. Our results are similar in line with results of the other published studies. Of course, like vertebroplasty technique for mobile spine, here also there are some complications. The main complication is cement leakage. In long axis technique, there is risk of leakage to the neural foramen. Actually, in short axis technique, there is almost no risk of leakage to the foramen, but in 2 of our cases, there was asymptomatic sacroiliac joint leakage to the sacroiliac joint. So the main concern regarding the sacroplasty is about biomechanical aspect of the sacroplasty. There are some studies support the effectiveness of sacroplasty, and some other studies do not support. But I would like to show you one study performed by Mears et al. They created insufficiency fracture in the sacrum, and then they did sacroplasty in one group. They put a short screw in one group and long screw in other group. So they said after cyclic loading, motion increased in all groups, and they concluded that all 3 fixation methods resulted in motion similar to that of the intact pelvis. Also, motion increased as a function of cyclic loading. No significant difference was found between the fixation methods. Therefore, there is no outcome-related difference between the stabilization and sacroplasty. So, of course, other surgical option is stabilization. And because this is a fight, I have to talk a little about the stabilization. As you know, we have different techniques for stabilization of the sacrum. You can do a complex construct, or you can do a percutaneous approach for screw placement. In left side, you can see one of our cases. This case was a girl, 16 years old. Even in this case, 3 years after surgery, I have seen one screw pull out. Imagine these cases are old cases, and surgery in these cases has many comorbidities. Particularly, we can see all osteoporosis surgery complications in these cases. Of course, you can do a limited surgery using these screws, but in these cases, you need to put at least 2 screws in order to avoid rotational instability. So, we should remind that these cases, sacroiliac fractures, are not high-energy fractures. They are osteoporotic cases. As in osteoporotic fractures of the mobile spine, we should inject, we should do augmentation of the sacral wing, particularly in cases with no deficit and no instability. And when we compare sacroplasty and stabilization, you should know that you can do sacroplasty under local anesthesia, pseudoanalgesia. It takes almost 20 minutes. 1 day hospitalization, early mobilization. There is a little risk of cement leakage. On the other hand, Stabilization can be performed under general anesthesia. It takes longer and longer hospitalization, and there is higher rate of the complications. And we should know that even in stabilization cases, we may still need cement augmentation. There are many complications about, after iliosacral leg screws, like neural injury, wound healing, infection, and there are a risk of screw malposition up to 15%. So, in summary, sacral insufficiency fractures occur in aged cases, with cases with poor bone quality, with many comorbidities. Stabilization adds morbidity and cost. This is what the previous speaker said here. And we should know that sacroplasty is effective and safe procedure in cases resistant to medical therapy. Thank you very much.